Good morning, clinical problem solvers. Thank you for joining us on this beautiful Wednesday morning, afternoon, or evening, based on what you are joining us from. And today we are fortunate to have with us Dr. Singh is there, even Rabi is there to share his wisdom, and Mary is there, and my dear friend Marilina is here as well. And we are looking forward to discuss case. And please, as always, share your thoughts in the chat. We always learn from your wisdom, and we would like to highlight it whenever we think it is absolutely necessary. So please don't hesitate. And Dr. Singh actually has agreed to present a case to us. And Rafa will help us with case presentation. And me and Marilina will go to and forth discussing the cases. So Dr. Singh, why don't you introduce yourself?
Oh, hi, my name is Ravi, one of the regulars on CPS, and I'm very glad to be here today with Kirtan and Madalena. They'll be discussing this case. It's a case we had a little while back, so I'm very excited to present this case.
Yeah, so before we get started, hi everyone, I'll introduce myself. My name is Madalena. I'm a medical student in New York, but taking a year off, so I'm in California right now. And before we get started, I think we should all send, congratulations and best wishes to Kirtan, who's about to start residency. So exciting for him, and I'm excited to discuss a case with Kirtan.
Well, thank you. So kind of you, Marilena. I need all of your best wishes. Friends, please share them along because, it's always a tricky transition. You have to be careful. You have to be focused. So I need all of your best wishes and blessings that I stay focused. I do my job perfectly and, stay committed to the patient care always and move forward as things come along, Thank you again.
You will do great. Okay, Ravi, I think we're ready to jump into the case.
All right, I'll just ask Rafa to share the whiteboard, and I'll start with the case. So we have a situation on the floor. So this will be something that Kirtan will be familiar with within the next week. The medicine team responds to a rapid response on a patient with tachycardia. At the bedside, you find the patient is tachycardic into the 160s, normal sinus, and blood pressure was found to be 120/80, respiratory rate 40s, oxygen 90s on room air. And I'll stop there for you to discuss the case.
Marilena, why don't you share your thoughts first?
Yeah. Sure. Okay, so a rapid response. Okay, so I'm just going to really summarize. Okay, so what we have here is that we have a rapid response due to tachycardia. We have the blood pressure was, Ravi, do you mind just repeating that? It was 120/120. Okay. Anyway, so we have tachycardic and hypoxemic as well. So the first thing that's going through my mind is when I hear tachycardia is I want to make sure, is this sinus rhythm or not? So we want to make sure if it's sinus tachycardia. If it's not, then we're in the schema of tachyarrhythmia. And so we'd want to know, is this supraventricular tachycardic? How wide is the QRS complex? Because I think that really dictates management. I don't have so much experience with rapid responses, but I know that management is often key here. So before putting so much effort into our differential, we just want to make sure the patient is stable. But I think what I would first be trying to determine is this sinus rhythm or not, because that would influence management. Kirtan, what do you think?
Sure, I think the approach is excellent because what if the patient is not in sinus tachycardia itself? What if the first assumption that the patient is in sinus tachycardia is wrong? Because if that's the case, then I agree with you that we need to go down the pathway of ACLS algorithms. That if the patient has tachycardia, then what if the patient is in imminent danger? So we should evaluate if the patient has altered mental status, if the patient has ischemic chest discomfort, because all of these things, if are present, then we need to get cardiology involved. We need to ensure that we have the pads with us so that we can do the defibrillation, we can do the synchronized cardioversion and all other antiarrhythmics and medications as may be required. But let's say if it is indeed sinus tachycardia, then how we can approach that? So I learned from our dear colleagues from VMR only that in tachycardia you have to think about two things, that whether it is a primary process or whether it is a secondary process. And by secondary, I mean there are numerous systemic disturbances which can lead to activation of sympathetic nervous system, and that can lead to tachycardia. So what are some of the common entities? So for instance, if the patient is hypovolemic, let's say due to hemorrhage, let's say due to nausea, vomiting, diarrhea, let's say due to third space fluid losses, then that can lead to compensatory tachycardia. And the patient has low BPs, as we can see from our aliquot. So maybe the patient has some degree of volume loss. So that maybe that is one of the reasons why the patient has tachycardia. Apart from that, endocrinologic disturbances like hyperthyroidism is there, elevated levels of, let's say, catecholamines are there. It may be primary or again secondary, because catecholamine levels can go up and down due to numerous reasons. So all of them can contribute to tachycardia, and rarely the primary cardiac process itself can contribute to tachycardia. So I guess in the next aliquot, we can focus on what are other symptoms, how the patient is doing mentally, and then we can move ahead. So Rafa, please take us away with next aliquot.
Okay, sorry for the delay. The blood pressure, I was trying to open up the other screen, Madeline. The blood pressure is 120s, 80s around there, so stable at this point. So the next aliquot is, so the patient is a 25-year-old male, no past medical history, who presents after being stabbed in the left infraclavicular region 4 days prior. He had a 3 centimeters wound and was noted to have decreased lung sounds on the left, requiring emergency chest tube placement in the ED. Per nurse, the patient has been tachycardic into the 120s for most of the stay and now has that chest tube in. But now the heart rate has worsened to 160s to 170s, and the patient has now developed tachypnea and restlessness. Regarding the past medical history, there's none, no social history, no family history, no surgical history except for this chest tube placement when he arrived 4 days ago, no medications, no allergies. And I'll get to the physical exam now. I'll let Rafa catch up. Okay, vital signs, temperature 37.1, heart rate 160s, blood pressure 110 to 120, systolic over 80 to 90, fluctuating, respiratory rate 40s, oxygen saturation 100% on 2 liters nasal cannula, general patient alert oriented, is anxious and restless, jumping to cardiovascular, has a rapid heart rate, regular S1, S2, no murmurs, no JVP, peripheral pulse is intact, lateral chest tube in place, draining serosanguinous fluid, no air leak noted. Respiratory, increased work of breathing with decreased breath sounds on the left lung, good air sounds on the right lung. Rest of the exam, GI, neurological is normal, and I'll stop there for discussion.
Wow, okay. So this, I am concerned about this patient. So what stands out to me is going back to kind of the additional history we got. So there was a recent trauma of a stab wound in the left infraclavicular area, and he's now has this chest tube placement. So when we move on to, when we look at the vitals, I think what really stands out to me is AMK and other people in the chat mentioned that for tachycardic, we want to look at the blood pressure and see if this is potentially response to hypovolemia. And especially with the recent trauma, you know, I would want to be concerned, is there an ongoing bleed that we need to identify? And people mentioned in the chat, you can do the POCUS exam. So the blood pressure is slightly reassuring to me, just because it's, you know, he is stable in that sense. But what really stands out to me is the respiratory rate of 40. That is extremely high. So what's going through my mind is this patient, do we need to intervene in some way to make sure that his airway is patent and he doesn't go into like further acute respiratory distress or failure? So I would not quite sure how I would be managing that, but I think that's just, it's very alarming to me, and I think I want to do something about it. What's also standing out to me jumping to the pulmonary exam is, so the increased work of breathing, decreased lung sounds, and the left lung fields. So if you're having decreased lung sounds, what comes to mind for me is there, is there fluid or is there air there? So for example, pleural effusion, could there be a pneumothorax potentially? And I know in the first aliquot, we had learned that he was hypoxic to the 90% on room air, but now he is back up to the hundreds. So I am very concerned about his respiratory status. That's kind of the summary of my concern here. And another thing I'm interested in is he has the chest tube in place. So have there been changes in how the amount that's been draining and the color of that? So that is what's standing out to me. Kirtan, what's going through your mind?
Sure, I just love how Madelina focused on the most imminent things, because the patient is in respiratory collapse. Almost patient can collapse anytime because of the very high tachypnea. So I guess, getting the pulmonology involved and getting ABG is very essential. And this is something which I learned when we are studying for asthma, that when the patient has tachypnea, and if you find that the PCO2 is almost normal, then it's not normal actually, because if you have tachypnea, then PCO2 should be very low, because you are hyperventilating basically. And if it is near the normal range, then it means that you are going into the state of respiratory fatigue and the patient can collapse anytime. So I agree with Madelina that we need to focus on that, because the patient can collapse anytime. And another interesting thing is that we were referring to the possibility of causes of tachycardia in the first aliquot. And we mentioned that maybe the patient can have hypovolemia, patient can have bleed. So now there is suspicion the patient may have internal bleed, if not external, because of this stab wound. And talking about the decreased bed sound, it is also important, because what in the fluid should be considered. So blood is a fluid. So what if the patient has pulmonary contusion? What if the patient has hemopneumothorax or just hemothorax? And there is also possibility of hemorrhagic cardiac tamponade, because it was in the left infraclavicular region. So there is also possibility that you could have ruptured or nicked the aorta somewhere or pulmonary artery somewhere. And now the blood is collecting retrogradely into the pericardium. And that's why, the BP is not too alarmingly low, but still a little bit low. What we should expect lower than that. And apart from that, there is also possibility of arrhythmias being triggered by this trauma, because whenever there is some sort of local irritation in the thorax, the heart can get irritating and it can produce arrhythmias. And lastly, I am also concerned about the possibility of some infection lurking in the background. So infection can't explain all the symptoms, but because of the stab wound, and I mean, the knife was there, the metal was there, so there is possibility of mediastinitis developing as well. So I will also look on other vital signs of the patient. If the patient develops fever, because mediastinitis is very concerning, the patient can rapidly deteriorate. So all these things are in my mind, that how we can fix how we can fix the lungs, how we can fix the heart, and whether the mediastinum is involved or not. So very interesting case, and I am looking forward to learn from Dr. Singh that what next events reveal.
Incredible job. Very good. Both of you doing really well with this case. But just this scenario can be very anxiety provoking. So you can imagine yourself being the internal resident responding to such a case, especially we don't deal with trauma a lot of times. So continuing on, laboratory studies, sodium was 132 and potassium 4.2. Carbon dioxide 23, creatinine is normal. I'll cut to the chase. CBC, white count 27, hemoglobin 8.9, MCV 70, platelet 537, lactate 4.7, PT 16.2, INR 1.3, and I have an X-ray. Let me share screen. This may be, Rafa, do you want to, okay. I'm gonna post up the X-ray, you can take a look at it. Kirtan, you wanna take first stab at this X-ray?
Sure, I can do that. All right. So, wow. I mean, How we can interpret this? So firstly, whenever we see the X-ray, we need to make sure that everything is, whether it is centralized or not. I mean, if there is tension pneumothorax, then you can see the mediastinal shift. So we should look for that. And apart from that, another common thing that we should look for is whether the blunting of costophrenic angles is present or not, because we were thinking about pleural effusion, like it could be hemothorax as well, or it could be one pneumothorax. So that way we can see whether costophrenic angle is blunted or not. And apart from that, whether free fluid is there somewhere, which could possibly refer to abscess or some sort of organ perforation. So we should look at the thorax as well as the abdomen, so as to make sure that multiple traumatic events were not present. So apart from that, let me see, what can I see? There are few hazy infiltrates in both the lung fields, which can refer to pulmonary contusion. And again, the patient was, slightly altered. So you can't rule out the aspiration event as well, which can also lead to chemical pneumonitis. But the infiltrates are not too concerning as such of now. But if you see, then in the left lower part, you can see that there is some sort of air collection there. So it might point us to a loculated fluid collection in the pleura. And maybe because of that, there is gas there, because, bacteria can be proliferating, or there is a airway port of entry from outside. So that patch is concerning to me. And then I am, looking forward to hear from Madelina that what does she thinks about this X-ray.
Yeah, Kirtan, I think that was such a fantastic discussion of this X-ray. X-rays can be really kind of intimidating to discuss, and you walked through that in a very structured and really just great job. So a lot of the things that you mentioned are also standing out to me. So what immediately stands out to me is this widened mediastinum and enlarged cardiac silhouette. I also, what you pointed out, the trachea appears to be deviated to the right. And so when I see that, I'm concerned about a pneumothorax. So then I look to see, are there any decreased lung markings? But I actually don't see any decreased lung markings. In the left upper lung field, I do see prominent lung markings. So I don't believe I'm seeing evidence of a pneumothorax here, but again, I'm no expert in interpreting X-rays, so would want some expertise on this. And then I do see what you're saying about this kind of darkened, potentially like an air collection, or I'm not sure how to describe that, but in the right lower lung field, I'm not sure what that is. But I think the takeaway here is an enlarged cardiac silhouette, some deviation of the trachea to the right. And I think, a pulmonary contusion is a great thought as well. But I don't see any kind of blunting of the costophrenic angles, which I would expect in a pleural effusion. So those are my thoughts.
All right, so great job looking through that. There's a lot of definitely noise going on. So we do know that this patient had a stab wound to the left in infraclavicular region, and you saw the left side had all that pathology there. And oh, great, you were able to snag the X-ray and put it in there, Rafa. So that definitely helps. And when you commented on the size of the heart, that does look enlarged, even though this was a portable film. So continuing on with this patient, the patient was level 1 trauma after this stab wound. He had that chest tube put in, he had a pneumothorax and was having good output, but remained tachycardic, and then was having some ST elevations in an EKG in lead V3, V4. An echo was done, which showed EF of 65% normal, ventricular size and motion. And then he continued having this chest pain, and the troponins worsened. And a repeat chest X-ray showed another left pneumothorax requiring a second chest tube placement. So the first one wasn't working properly. The chest tube was then removed eventually, but then he continued having chest pain. And then this rapid event happened. And I'll stop there if you want to discuss your final thoughts before I go through what happened or what is the reason for this patient's tachycardia. Madelina, you want to start?
Yeah, so there's a lot going on in this case. And I think I just want to, acknowledge that. And I think importantly, this person is extremely ill. So I think we need to be really systematic about this and really thoughtful about the management here. Something we didn't have a chance to discuss the labs, but something that stood out to me were the white blood cell count at 27, which is extremely high. And I think that some things that cross my mind there is this a response to kind of the stress the body is under right now. I think infection you want to consider as well. And then the hemoglobin a little bit low, maybe from kind of just the trauma, but we don't have the baseline value, which is something that we would want to see. So just kind of scanning through the other data that we have here. So for the EKG, the ST segment elevations echo with preserved ejection fraction. So the ST segment elevations in V3 through V4 are concerning for, is there ischemia to the myocardium in some way, and then he had this tachycardic episode afterwards. So, and increased levels of troponin. So I'm concerned about ischemia to the myocardium, and those are my thoughts at this time. Kirtan, I would love to hear what you're thinking.
Sure, I agree with you that, WBC, which is elevated, it can be a sign of infection, maybe mediastinitis, which we were talking about earlier, but it could also be just because of elevated catecholamines and demargination of the neutrophils from the vessel walls. And that's why we are getting leukocytosis. And same might be true for thrombocytosis, because like the most common cause of thrombocytosis is usually the reactive thrombocytosis, maybe due to anemia or due to bleeding or due to stress response. So that can explain the left findings. And regarding troponin, I agree with you that it is very intriguing. So like we have some sort of ischemic chest discomfort, and that's why we are getting elevated troponins. So now I learned this, that what can cause ST elevation. So if we start from the basics, first we have the myocardial infarction, the most feared one. And in our case, can it happen? So there is one possibility. So as we discussed that maybe the patient has aortic dissection and aortic rupture, something like that. So we know that aorta retrogradely, if the dissection occurs, then it can involve the right coronary arteries, which is very common, and even left coronary arteries can be involved. So like the dissection can move retrogradely and involve the coronary vessels, which can explain the ischemia in our part. Apart from that, what else can cause elevated troponins? And ST segment elevation classically. So myopericarditis can cause ST segment elevation. Usually they cause diffuse ST segment elevation, but in our case, since there is evidence of trauma, we should consider the possibility of myopericarditis along with or without tamponade. Then there is possibility of this myocardial contusion. So just like pulmonary contusion, you can have myocardial contusion. So just like how trauma to any organ can elevate the enzymes, like if you have muscle trauma, you get rhabdomyolysis and you get elevated CK levels. So same is true for heart. Like if you are hitting the heart, if you are traumatizing the heart, then the troponin should go up and you will have ST segment elevation. So that is one way to look at it. And lastly, sometimes Takotsubo cardiomyopathy can also present in this way, but the history is not consistent with that. So like this is the way we approach the ST segment elevation. And again, the leads in which the ST segment are elevated can guide us. Like if it was in the right-sided leads, then maybe pulmonary embolism could be a concern. But again, the history is not compatible with that. But still, we should look for embolism, tamponade, coronary ischemia, and all those things. And I guess that's how we can move ahead. And lastly, one rare possibility, anatomically, I would mention that in the chest tube drainage, you were getting lots of blood. And when you have trauma, you should consider the breach of various anatomical planes. So like you can get pleuropericardial fistula, you can get pleuropulmonary fistula, all sorts of fistulas. And that way blood can drain from one anatomical space to another anatomical space. So that is one thing to consider apart from pulmonary contusion and myocardial contusion. So I guess those were my thoughts. And maybe now Dr. Singh enlighten us that how the team was thinking in the real time and how we can learn from that and move ahead.
Oh, absolutely brilliant. You're right on to what's going on with the patient. So first of all, addressing the white count, that was a very good pickup, Madalena. So the patient actually had findings in the, let me just look through, the patient did have actually a pericardial effusion. So both of you had picked up on that large heart, and with the drop in blood count, when initially has a hemoglobin which is in the normal range. So with the drop, there's anemia, and that can explain the tachycardia, but the patient didn't have tamponade physiology. And the fluid was positive for staph. So antibiotics were started, and the patient underwent a pericardial window and placement of a left thoracostomy tube. Patient eventually had VATS and was also found to have empyema. and so was placed on intravenous antibiotics for 2 weeks and then discharged, and everything resolved: the white count, tachycardia, anemia, and so on. So great job. You guys picked up on the white count, the anemia, all the possible causes, the troponin, the cause of troponin, and the ST elevations, even though it was in 2 leads. Definitely you were able to figure out what could be in the differential.
Ravi, just a question on that. Would that be chronic anemia that was pre-existing to the blunt wound?
No, I think the patient had the normal hemoglobin to start with, and this hemoglobin was 8.9 when he came in.
What do you
Wow.
think, Madeline?
Wow, I have so many reflections on this case. I think one, just reflecting on what it was like to go through this, I definitely had a little bit of tachycardia. I think this was a very, I can imagine, stressful case for everyone taking care of the patient, because he was, this is a trauma case, he was so ill. So I found myself, it was challenging to kind of take in all the data that was coming our way and try to incorporate that into the best course of management, because I think here management was key in addition to diagnosis here. And yeah, it was just so much fun to discuss, but really, really challenging. And Kirtan, I couldn't think of a better person to co-discuss this with. I guess one question I have for Ravi is, to what extent is this kind of a consequence of the trauma that occurred versus kind of a secondary, pathology that developed?
Sorry, I was unmuting my mic. Yeah, I'm not sure with the stab wound, there possibly was introduction of infection from that event, or there could be something that was bubbling under the surface and patient presented with this stab wound. So I don't have that information. This case is a couple of years old. I just presented it, from the hip, so spontaneously as a case. But yeah, I don't know the sequence to really explain why this infection was there, but it was something else that was bubbling under the surface.
Yes.
Amazing.
Thank you again, Marina, for discussing with me. It was very nice to see that how you go down to the bottom of things, like you need clarification in order to learn more. So I like that. And lastly, I would like to make one brief comment on this staph myopericarditis. So I learned this from ACP journal, like the American College of Physicians journal, that often we think of staph aureus, we immediately our mind jumps to endocarditis. But we also need to understand that after all, endocarditis is just the inner layer of heart, and myocardium is right there sitting besides it, right? So if there is endocarditis, why can't be myopericarditis be a consequence of staph aureus infection, right? So many times it happens that patients who have staph aureus bacteremia, they may not get endocarditis. So like if you do the echocardiography, it will be fine. If you do the blood culture, sometimes even they may be fine, but still there will be localized infection of the myocardium and pericardium. So that can cause myopericarditis. So all the chest pain, enzyme elevations, ECG changes. And in our case, as it turns out, it was the case, like it was not endocarditis, but it was localized myopericarditis because of trauma. And maybe even systemic infection could be there, as Dr. Singh mentioned, but trauma was like more likely. So I will take away that message from this case, that I will always remember that staph aureus can also cause myopericarditis and not just endocarditis. So thank you again for teaching us that, Dr. Singh. Thanks to Rafa for scribing. And thank you, Madalena, again for discussing with me. And now teaching points, please take us home.
Yeah, again, great job. Hopefully this case was, I remember I said it's not too bad, but you guys did a great job. Or both of you did a great job in tackling it, and very physiology based. So initially we started off with the complaint of tachycardia, and Madalena did a great job to determine if this is just sinus tachycardia, or is this another arrhythmia? Is this narrow complex, wide complex, regular? So going down those branch points. But then ultimately you need to make sure, is this patient stable? Do we need to implement invasive measures, doing your ABC, so implement ACLS. Also, we need to get pads, get nursing care in, get a defibrillator on board in case you need that. Kirtan did a great job in determining if this tachycardia, breaking it down, if there's a primary or secondary process. Numerous processes can lead to tachycardia, mainly in volume loss. Could this be hypovolemia, anemia, or you could have endocrinopathies like hypothyroidism. And then primary could be cardiac issues where you may have like cardiomyopathy or other infiltrative disorders where you can have arrhythmias. The respiratory rate, that was great actually. Respiratory rate definitely stood out. This patient was in jeopardy with a respiratory rate up in the 40s, and this also can be a harbinger of instability. So need to intervene, get all hands on deck, get pulmonary, get possibly ICU step down consult as the patient's heading towards respiratory failure. The pulmonary exam showed increased work of breathing, decreased lung sound. So what could there be in the airspace, or what could there be in the lungs? So fluid, air in the pleural space, pneumothorax, pleural effusion were entertained. And also look to the chest tube. Patient has a chest tube, and this was the problem. The patient, she had a chest tube, and then the patient had decompensation, then needed increased oxygen requirements, and then had a second chest tube placement. So that was right bang on that the chest tube could also be at fault here. And then Ketan also went through tachypnea, that this is a finding that the PCO2 should be low, but if there is a normal CO2, the patient could be having hypercarbia and could decompensate rapidly, or could be tiring out. Again, going back to tachycardia, now bleeding is a concern. Could during this assault, could a neighboring structure be injured? So could they have been nicking of one of the vessels, aorta, pulmonary contusion? Could this also have been at play in something that manifested 4 days in? Think about pneumothorax, hemopericardium, and this can also result in possibility of arrhythmia being triggered. Lastly, also infection. So any spillage of contents into the mediastinum can cause mediastinitis, which can be an emergency. And picking up on the Y count was definitely a good finding, that infection and the thrombocytosis could be due to bleeding anemia, but this could also be acute phase reactant, the thrombocytosis, or it could be due to stress. But signaling that infection could be at play here is definitely something that was part of the patient's presentation. And then with the EKG, this ST elevation, could it be a sign of ischemia? So the first thing to think about is ACS, but what if this is due to another finding, maybe pericarditis, maybe pulmonary embolism? Could there be dissection into right coronary vessels as well? And then the elevated troponin, not anchoring just on acute coronary syndrome, but could this be a disturbance to the myocardium, so myocarditis, pulmonary embolism, or in this case, pericarditis could result in some elevation of troponins. And that's the end of the teaching points.
Ravi, thanks for presenting this awesome case. It was so much fun to go through, and I learned a lot. So thank you.
Thank you. Great discussion.
Yeah. Thank you all for joining, and see you tomorrow with another case. Have a great day. Bye.